I will talk about the medulloblastoma in children. You know that the brain in children, the brain tumors are the second most common cause of death after leukemia. Medulloblastoma is mainly a pediatric brain tumor that accounts for 10% of all intracranial neoplasms and 30% of all pediatric fossa tumors in children, whereas they present less than 1% of tumor adult neoplasm, neurotumor adult neoplasm. Medulloblastoma is a highly malignant neuroepithelial tumor of the posterior fossa classified who grade 4. Medulloblastomas are located in the vermis and the fossa in the third ventricle in children, but in adults, it's located in the cerebellar hemisphere. Medulloblastoma represents about a third of all posterior fossa tumors. The name of medulloblastoma was originally introduced by Bailey and Cushing in 1925. In 1925, I isolated a type of glioma which occurs chiefly in the center of the cerebellum of children, for which I suggested the name medulloblastoma. Subsequently, Harvey Cushing published a comprehensive study of this tumor entity. The term will be remain to this day. Medulloblastoma children statistics approved by the Cancer Net Editorial Board, February 22, about 500 children in the United States. In French, the incidence of medulloblastoma is 5 to 10 cases per million children, corresponding to approximately 150 new cases per year. The American Epidemiological Surveillance reports a decrease in the incidence of medulloblastoma, while the incidence of supratentorial locations of primary neuroectoderm tumors is increasing. Medulloblastoma is a tumor seen at all ages, but 75% of tumors occur in children with a median age of 9 years. Boys are more often affected than girls. Medulloblastoma is a tumor located in the posterior cerebral fossa. To understand better the symptomatology of this type of tumor, so we do anatomical. We must do our anatomical reminder. The posterior cerebral fossa is anatomical space with the container and containers. About the container, the posterior fossa extends from the tentorial incisura through which it communicates with the supratentorial space through the foramen magnum, through which it communicates with the spinal canal. It is formed by 3 bones, sphenoid, temporal, and occipital. About the contents, the posterior cranial fossa accommodates 2 parts of the brain, cerebellum and brainstem, and we have a 4th ventricle between the cerebellum and the brainstem, and also we have a vascular system. So the symptomatology of the medulloblastoma may be related to direct cerebellar involvement, related to obstructive hydrocephalus, related to metastatic meningeal dissemination. They are most often expressed as intracranial hypertension syndrome. This is the predominant clinical signs in medulloblastoma and is the mode of presentation in over 70% of cases. The main signs of hypertension, intracranial hypertension is headache, vomiting, visual disturbance. So the last can be seen as a simple reduction or at a more advanced stage as total blindness with optic atrophy. Diplopia is most often found due to the damage of the sixth nerve. Cerebral syndrome is the second most frequent clinical signs found in the medulloblastoma. Can be static or kinetic or statico-kinetic. Static, it is manifested by problems with walking and standing. Kinetic, it is expressed by coordination disorders. Statico-kinetic, combining the signs of static and the kinetic cerebellar syndrome. Third symptoms, vestibular syndrome is manifested by vertigo, nystagmus, and a positive Romberg test. Fourth, involvement of the lung tractus. This is seen in a very advanced tumors which comprise the brainstem and produce a pyramidal syndrome of the forelimbs. About the cranial nerve involvement, cranial nerve damage can be found in 20% of cases. About the imagery, CT scan and MRI are the main radiological examination to evaluation of the medulloblastoma. Medulloblastoma in CT scan present as a tumor of the posterior fossa, median, limited, of homogeneous density, spontaneously hyperdense in 80% of cases, and homogeneous after injection of contrast medium. MRI allows us to specify the exact location of the tumor, its dimension, and its impact on the ventricular cavities. The infiltrative character in the fourth ventricle, the brainstem, the cerebellar peduncle. In T1, the solid tumor mass is often heterogeneous with iso or hypothenial in relation to the gray matter, hyperthenial for the hemorrhagic areas. Cysts are visible in 75% of cases. In T2, the mass is hyperdense in relation to the CSF in the cyst and necrotic areas. The hemorrhagic areas are sometimes markedly hypothenial. About the macroscopic aspect, medulloblastoma is a solid greenish-red, soft, friable tumor with a clear boundary and infiltration of the perivascular spaces of the surrounding tissue. There are often soft areas of necrosis and or fluid. But the microscopic aspects, we have three main histological types of medulloblastoma are defined according to the WHO classification 2007. We have a classical types, desmoplastic types, and anaplastic types. The standard classification as proposed by, we have 4 types of tumor, T1, T2, T3, and the T4. We have 2 subtypes of T3, T, E, and the B. About the metastasis, we have 5 types, M0, M1, M2, M3, and M4. About M0, we haven't metastasis, but M4 metastasis outside the central nervous system. Medulloblastoma are currently distinguished into 2 groups. So we have medulloblastoma with a standard risk and a medulloblastoma with a high risk. About the standard risk, we have medulloblastoma with a total of or a subtotal excision with absence of subcontorial metastasis or along the spinal axis, absence of meningeal dissemination. A high-risk medulloblastoma we have a residue tumor superior than 1.5 centimeter square, and or existence of supratentorial or spinal axis metastasis, and or presence of cerebrospinal fluid invasion. What about the treatment of medulloblastoma? The treatments for medulloblastoma usually include surgery followed by radiation, chemotherapy, or both, with the aim of increasing survival through good local control while reducing the risk of squamous. Treatment of medulloblastoma include several options. The first option is the treatment of hydrocephalus, the hydrocephalus. So in the treatment of the hydrocephalus, we have two methods: intracranial and intrathecal and extrathecal treatment. In the intrathecal treatment, it consists to performing any endoscopic ETD. Extrathecal treatment consists to perform a ventricular-peritoneal drainage valve is used. The second option is the surgery to remove the medulloblastoma. The goal of the surgery is to remove all of the medulla, to remove the tumor, because it forms near important structures deep within the brain. These pictures, we have a different stage of intervention for surgery of medulloblastoma. In this picture, we have installation of the patient in a down or in a prone position or in stated position, drawing the incision. The last pictures we have in this picture craniectomy after incision of opening of the dura mater, exposure of the tumor here, and these pictures on these pictures we have excision of the tumor. The third option is radiation therapy, use the power energy to kill cancer cells. Fourth options, chemotherapy, use medicines to kill cancer cells. Typically, children and adults with medulloblastoma receive these medicines as an injection into veins. Chemotherapy may be used after surgery or radiation therapy. Sometimes it's done at the same time as radiation therapy. Treatment strategy. Surgical removal is most often the first step in the treatment of the medulloblastoma. In some cases, a simple biopsy will be performed initially to diagnose the disease, and removal the tumor will be scheduled after chemotherapy. The standard post-operative treatment is the posterior fossa irradiation combined with brain and the spinal cord irradiation. The combination of surgery and irradiation at this dose has resulted in 5 years survival of about 50%. All risk levels considered. However, long-term monitoring of these patients have shown that such treatment leads to morbidity, especially cognitive and endocrine morbidity, which is more important when the child is young at the time of treatment. So, currently, the treatment is adapted to the age of the child because of the after effects of radiotherapy. We have children under 5 years of age. Post-operative treatment of children under 5 years of age with medulloblastoma is tailored to the type of the medulloblastoma. Nodular desmoplastic medulloblastoma is a form of medulloblastoma with a very good prognosis at this age. Children over 5 years of age, treatment is currently satisfied with the quality of surgery. Our study, so we have a study, a retrospective descriptive study performed in Department of Neurosurgery of Oran, Algeria. We had 50 cases. The duration of the study is 2 years. We had inclusion criteria. We include all patients whose age is less than or equal to 15 years with a tumor of the posterior cerebral fossa. Frequency, brain tumors in children account for 25% of the department's activity during the study period. 40% of these childhood tumors are located in the posterior cerebral fossa. The average age is of our patients is 7.6 years, with extremes of age between 3 months and 15 years. We have a slight male predominance. Mode of admission of our patients. So 35% patients admitted by emergency, 10 patients admitted and or readmitted through consultation. So the main functional symptom of our patients. Physical signs, intracranial hypertension syndrome is the most frequent reasons for consultation of our patients. We have macrocrania, acute headache, and vomiting. Ophthalmic and oculomotor signs. The fundus examination carried out in 13 patients showed papilledema in 12 patients, while it was normal in 2 patients. Damage to the sixth pair of cranial nerves was found in 5 patients in the form of diplopia in 1 patient and strabism in 4 patients. Cerebellar syndrome detected in 25 patients with static cerebellar syndrome noted in 10 patients, kinetic noted in 3 patients, statico-kinetic in 12 patients. About the CT scan, all patients were received with a cerebral CT scan. This examination raised the diagnosis of medulloblastoma in 100%. 5 patients have so the location, the median localization of the lesion was the most found in 30 patients involving the vermis and the fourth ventricle. 5 patients had a mixed localization at the same time, median and the cerebellar. Obstructive hydrocephalus was found in over 90% of cases. Metastatic lesions above the tentorial level were noted in 2 patients with a right frontal location and an intraventricular one. About MRI, it allows to locate the tumor, to measure the size and its extension in the 3 planes. About a complementary medullary MRI has always been requested in the perioperative period, either pre-operatively during any MRI for the planning of surgery, or post-operatively as part of any extension assessment before planning adjuvant treatment. This examination was carried out in only 29 patients of cases due to the poor socioeconomic condition expressed by 16% of cases. Surgical treatment of hydrocephalus, so internal ventricular shunt was decided in 25 patients, of which 23 cases was practiced secondarily in 2 patients when the hydrocephalus persisted after the surgery. ETV performs in 17 cases. So 15 cases in referred surgery and 2 cases of failed internal bypass. About the tumor resection, so in this table we have the quality of the tumor removal according to the location of the lesion. Evolution was favorable in 19 patients. 21 patients had complications. The main post-operative complications are meningitis, actinic mutism, and mixed nerve palsy. We had 5 deaths. Complementary treatment, 22 patients were referred to the oncology department for adjuvant therapy based on radiotherapy alone or associated with the chemotherapy. Average time to start adjuvant treatment, so the time between the surgery and the first session of adjuvant treatment is 95 days for chemotherapy and 69 days for radiotherapy. Evaluation criteria of therapeutic response are improvement of the general condition, regression of the clinical signs, decrease of the tumor volume. We have noted 5 cases of recurrence and we had 5 deaths, so the mortality rate are 12%. In conclusion, medulloblastoma is a malignant tumor of the cerebellum with a high potential extension, or sometimes insidious symptom might delay the diagnosis. The initial management includes an accurate assessment of extension and the surgical removal of the tumor, treatment associated with adjuvant radio and the chemotherapy. The prognosis is determined by the local and the metastatic extension of the tumor as well as the degree of the surgical resection. Thank you.